Dear audience, welcome to the progress report of my PhD thesis investigating the cardiac complications associated with acute pancreatitis. My name is Veronika Lillik. I'm a second-year internal medicine resident at the Hospital of Székesfehérvár, and my vision is to decrease the mortality of acute pancreatitis by foregoing the preventable complications, and that's why I try to conduct a high-quality research to understand the bidirectional relationship between acute pancreatitis and cardiac complications. So my topics revolve around this. We are investigating the interaction between the heart and pancreas in acute pancreatitis. My first project is done by the methodology of meta-analysis and systematic review. As you know, acute pancreatitis is a systemic inflammatory disorder with rising incidence and high mortality in the severe cases. Organ failure is one of the most important predictors of the severity and mortality, and heart is a common organ involved in the cause of death. The post-discharge mortality in acute pancreatitis is under-investigated. And the recent registry analysis showed that the mortality during the first 90-day period is almost the same as during hospitalization, and 22.5% of that is because of cardiac failure. That's why there's a need to cover the importance of cardiac-related abnormalities in acute pancreatitis. In cohort studies, it has been shown that the severe form of acute pancreatitis is associated with certain ECG, cardiac laboratory marker, and echocardiographic changes, cardiovascular failure, and myocardial dysfunction. The severity is determined based on the revised Atlanta classification into 3 categories, mild, moderate, and severe, based on the presence and the duration of local and systemic complications. Our aim was to investigate this bidirectional association between cardiac changes and acute pancreatitis outcomes. The clinical question was what cardiac-related abnormalities are associated with worse outcomes in acute pancreatitis. The population was patients with acute pancreatitis. The factors were certain cardiac changes, and the outcomes was mortality, severity, and length of hospital stay. We used another framework where the population was the same, but here the factor was the severity of acute pancreatitis, and the outcomes were the cardiac-related changes. We conducted a systematic search on the 5th of November 2023 with the following search key, and the search yielded around 20,000 articles, and after selection and citation and reference chasing, we ended up with 50 eligible articles. I will show our results on forest plots. We included in this first one 7 observational studies with around 1.7 million patients. The investigated factor was the presence of pre-existing chronic heart failure, and the outcome was in-hospital mortality. We can conclude from this forest plot that patients with pre-existing chronic heart failure have 3.43 times higher odds for in-hospital mortality during acute pancreatitis compared to those without chronic heart failure. On this forest plot, we included 6 observational studies with 1.2 million patients. The investigated factor was the presence of atrial fibrillation. The outcome was in-hospital mortality. We can say that patients with concurrent atrial fibrillation have 2.7 times higher odds for in-hospital mortality during acute pancreatitis compared to those without atrial fibrillation. In this forest plot, the factor is the moderate and severe acute pancreatitis, and we compared it to the mild category. The outcome parameter is the presence of abnormal repolarization on ECG. We can see that patients in the moderate and severe acute pancreatitis group have 2.75 times higher odds for abnormal repolarization on ECG compared to those in the mild category. In this plot, we also could compare the severity categories, and the outcome parameter was the QTc, prolongation on ECG, which means premature depolarization, and it can lead to fatal arrhythmias, for example, ventricular arrhythmia. and we could see that patients with severe and moderate acute pancreatitis have 2.25 times higher odds for QTc prolongation on ECG. The limitation of our study is that the time frames and the definitions slightly differ because of the retrospective nature of the studies, but this is the first comprehensive analysis on this association between cardiac abnormalities and acute pancreatitis, and we could include, in certain cases, high number of patients. We can conclude that patients with acute pancreatitis and concurrent atrial fibrillation face a threefold increased odds for mortality, and those with severe and moderately severe acute pancreatitis are 3 times more likely to develop changes in repolarization on ECG. The implication for practice is that cardiology screening in patients with acute pancreatitis is needed, at least ECG, and the implication for research is that higher quality and longitudinal studies are needed to assess this association, and more kinds of cardiac abnormalities needed to be investigated. We got our first rejection from Lancet Gastroenterology, and we resubmitted to Gastroenterology, and it is under review now. My second project deals with the same topic. We are doing a registry analysis to understand the cardiovascular abnormalities before and during acute pancreatitis. We are doing a post hoc analysis of the Prospective Hungarian Pancreatic Study Group database, because we would like to have an answer to the question what pre-existing and newly developed cardiovascular abnormalities are associated with worse outcomes. The population will be this database with acute pancreatitis patients. The investigated factors are the cardiovascular abnormalities available in the acute pancreatitis registry, and the outcomes are mortality, severity, and length of hospital stay. Below you can see the details of the data collection and validation, and this registry already has an ethical approval. We hypothesize that pre-existing cardiovascular diseases like hypertension, heart failure, atrial fibrillation worsens the outcomes of acute pancreatitis. Also, acute pancreatitis leads to newly developed cardiovascular alterations like ECG changes, echocardiography changes, thromboembolism, stroke, and they also worsen the outcomes of acute pancreatitis. Our third hypothesis is that the risk of acute vascular diseases are higher in acute pancreatitis compared to the general population. Now we are at the phase of the additional data retrieval, because I mentioned this will be a post hoc analysis, so we need the cardiac information looking back at the patient discharge forms, but the clinical administrators are working really hard on this, and I'm really grateful to them. Our third project is a prospective study to look at these pancreatitis-associated cardiac complications during and after acute pancreatitis. So we are planning to conduct a prospective observational multicentric follow-up clinical studies to answer to the question what are the incidences of these changes, when are they occurring, and what is the association between them and the acute pancreatitis outcomes. The most important question is that which in-hospital cardiac-related changes are associated with worse post-discharge outcomes. That's why we look at the acute pancreatitis population with certain cardiac changes, and the primary outcome is the severity of AP during hospitalization and the post-discharge overall mortality. But additionally, we would like to analyze the post-discharge mortality and the acute cardiac failure hospitalization rate among these patients. The clinical implication could be that cardiac screening is not only important during hospitalization, but also after discharge to detect the changes early and to prevent the cardiac mortality after discharging these acute pancreatitis patients. This is the planned flow chart. We are discussing it with cardiologists. We would like to have cardiac laboratory markers every day, like troponin, CKMB, NT-proBNP. We would like to have ECG regularly and echocardiographic monitoring of these patients. We are now drafting the protocol and we are planning to conduct the questionnaires next. This is the summary of my ongoing projects regarding the bidirectional relationship between cardiac changes and acute pancreatitis. And I would like to wrap up my presentation with a quote from Albert Einstein: "Life is like riding a bicycle. To keep your balance, you must keep moving." Thank you for your attention.
Thank you, Veronika. Do you know what could be behind the ECG alterations you observed in your first project?
Yes, our first thought was the electrolyte imbalances. For example, potassium, magnesium can lead, and hypocalcemia can lead to QTc prolongation. Regarding the repolarization changes, which is the lack of oxygen to the myocardium on the ECG. There are a lot of ideas, for example, vascular pathomechanisms like vasoconstriction, and the other one is this myocardial depressant factor that is released from the pancreas during pancreatitis, and it causes for the myocytes to work less or not so good.
Is there any question on the floor? I think those are very important results, and I'm looking forward for the result of your prospective study, because cardiovascular complications are really a big part of the cause of mortality in acute pancreatitis. So go for that.
Thank you.
But I have a question regarding your first study. So in your second study, in the registry analysis, you are planning to analyze separately the already prevalent cases and the newly diagnosed ones. Is there a possibility to create subgroups, or what is happening in the studies that you included in your meta? Are they differentiating these populations?
Yes, so the majority of the included studies, so at least the meta-analyzed studies excluded the pre-existing cardiac conditions, but we included some articles who described these cardiac comorbidities and then reported some data, but mainly they are in the systematic review part, so we are reporting them, but this wasn't the plan. The plan was to exclude them, but now we have a bigger picture of these alterations.
I would like to ask you regarding your last part of your research, the prospective plan study. Do you think it is important to do a lab result every day for at least a week for every patient?
I have a slide on NT-proBNP here in the meta-analysis, and we only found 3 of them. And as you can see, this is a really large confidence interval, so this means nothing exactly. And this is only one NT-proBNP level. And we have to see the changes, and we have to have more information about this
every day?
Marker, yes. And
do you think your patients will like you for this?
You at the Pancreatic Institute, I don't work there, but and even in Székesfehérvár, we take blood every day for acute pancreatitis patients because of the registry. So
instead of doing something else for them.
Yes.
You do lab results every day.
So we drew blood every day, so we can analyze troponin and NT-proBNP from that too.
in Kecskemét there's a department also. They're doing lab result for a patient every day. But one day they do like a potassium level. The next day they will do a liver function test. The third day an amylase level. But you can do it in groups.
Yeah.
So that's why I'm asking. I mean, what is the reason to do the same labs every day? Is it just because you are curious, or does it have a clinical relevance?
I see. It has a clinical relevance, at least as the protocol in our ward is that to have a laboratory result every day. For example, CRP is really important because when it starts to drop, you can refeed the patient and so on. And if you draw blood for CRP, then why not for troponin too? Okay. But the clinical relevance, for example, in the electrolyte levels are also important. This calcium and potassium, and then the ECG change, we can see.
Could change day by day in a severe case.
Yes.
Yeah, of course. Yeah.
But don't ask the director of the hospital how much it costs.
That's another question.
Okay, Veronika, thank you very much.